Hey everybody, let's jump right into this explainer on local anesthesia. If you've ever felt completely overwhelmed by pharmacology, you are in the exact right place. Today we're breaking down classifications, mechanisms, side effects, the whole nine yards. We'll treat this just like a whiteboard session. By the time we're done, this complex medicine is going to make perfect sense. Let's dive in. Quick shout out to the confused neuron channel for perfectly capturing this exact feeling. Look at this little guy. We've all been this completely confused neuron at some point, right? Staring at a textbook, totally overwhelmed by lipophilicity and ion channels, wondering how any of this actually helps a patient. Well, scratch that feeling. Today, we are saying goodbye to the confused neuron. We are going to learn, understand, and remember. All right, let's start with the absolute basics here. What even is local anesthesia? Put simply, it's making one specific part of the body numb to relieve pain or do surgery. The key word here is specific. We are not knocking the patient out cold. Because we're just targeting one area, local anesthetics are vastly safer than systemic, general anesthetics. Honestly, they're the preferred choice in the clinic whenever humanly possible. Okay, imagine I'm drawing this on the whiteboard for you right now. Every single local anesthetic molecule shares a really similar anatomy made of three main chunks. On the left side, you've got the aromatic portion. This is the lipophilic side, meaning it absolutely loves fat. Over on the right, you have the amine group, that's hydrophilic, so it loves water. And right smack in the middle, holding them together, is the intermediate chain. This chain is either an ester or an amide linkage. This kind of tug-of-war between the fat-loving end and the water-loving end, that is the secret sauce to how these drugs actually work.
But wait, we run into a huge chemistry problem right off the bat, the salt dilemma. See, local anesthetics are weak bases by nature. If you tried to just inject a pure weak base into a patient's watery tissues, it would literally just sit there. It won't dissolve. It's completely water insoluble. So what do the pharma companies do? They manipulate the crud out of it. They add a hydrochloride salt to that weak base. Remember basic chemistry? Acid plus base equals salt. Boom. Now the drug is water soluble, it's stable, and it's perfectly ready to be injected.
Now here's where it gets super cool. Once you inject that water-soluble drug, it hits the body and equilibrates. It actually splits into two different forms. First, you have the ionized form. This stays water-soluble, which is great because it lets the drug comfortably hang out in the interstitial fluid after you inject it. But you also get the non-ionized base form. And this form is lipophilic. Why on earth does that matter? Well, think about the nerve cell membrane. It's a lipid bilayer, right? It's made of fat. So that non-ionized, fat-loving form is the VIP that actually cruises right through the nerve membrane to get inside the cell. So let's build out our mechanism of action algorithm step by step. Step 1. That non-ionized base diffuses right through the fatty nerve membrane. Step 2. Once it's inside the watery cytoplasm of the cell, the drug actually reionizes. Step 3. And this is the absolute knockout punch. This newly ionized drug binds directly to anesthetic receptors on the inside of the sodium channels. Step 4. It physically blocks sodium from entering the cell. And Step 5. No sodium entry literally means no depolarization. The nerve is physically blocked from firing a pain signal. You are efficiently numb.
Section 1. Classification Showdown. Esters versus amides.
All right, so we know how they block pain. Let's look at a rapid-fire pharmacology comparison based on that intermediate chain we drew out earlier. Basically, it's a showdown between esters and amides. Esters are metabolized right there in your blood plasma by an enzyme called plasma butyryl cholinesterase. Say that 3 times fast. Because they get chewed up in the plasma so incredibly fast, their half-life is very short. Amides, on the other hand, are a totally different story. They have to travel all the way to the liver to be metabolized by hepatic isozymes, which means their half-life is highly variable.
And you know, imagine I'm highlighting this next point in bright red on the board because it's absolutely crucial. If your patient has liver impairment, like cirrhosis or severe hepatitis, you have got to be incredibly careful with amide anesthetics. Think about it. If the liver enzymes are failing, the body simply cannot break down the amide drug. It'll just build up in the bloodstream and cause severe systemic toxicity. Overlooking a patient's liver function when reaching for an amide is a massive, dangerous mistake. Okay, so how do we actually memorize which drugs are esters and which are amides without losing our minds? Well, here is the absolute best medical mnemonic trick. Seriously, it's a lifesaver. Just look at the generic name of the drug. If it's an amide, it will always have 2 letter I's in the name. Just look at the spelling. Lidocaine, bupivacaine, mepivacaine, 2 I's. If it's an ester, it only has 1 single I in the name. Procaine, tetracaine, benzocaine,
Boom! You'll never mix them up again.
Let's shift gears now to our delivery techniques algorithm. How do we actually give these medications to a patient? Well, there are a few main ways. Regional anesthesia numbs a specific, larger area of the body. Surface or topical anesthesia is applied directly to the mucous membranes. Then you have infiltration, which is when you inject directly into the skin or deeper structures you're actively working on. And finally, a field block is when you inject subcutaneously to block all the nerves distal to the injection site. Oh, and a quick pro tip for you. Small, unmyelinated nerve fibers, the ones responsible for pain and temperature, are always the most sensitive to these blocks. They literally go to sleep first.
So let's ground this in the real world with a few clinical scenarios. If an ophthalmologist is doing an eye exam, they're going to use surface anesthesia, something like tetracaine 2%. But if you're down in the ER doing an incision and drainage of an abscess, you're going to use infiltration anesthesia, probably grabbing some lidocaine or bupivacaine. And if a dentist is pulling a tooth, they'll use a field block with lidocaine 1 to 2% to completely numb everything downstream of that specific nerve.
Section 2. Toxicity, side effects, and contraindications.
Now, every single medication has trade-offs, and first up is a massive, flashing red light contraindication: ester cross allergies. Esters have a notoriously high rate of allergic reactions, so if a patient tells you, "Hey doc, I'm allergic to procaine," you need to listen. Because of their chemical structure, if they're allergic to one ester, they are highly likely to be allergic to all esters. It's a package deal. In this case, you would safely switch over to an amide-class drug, like lidocaine, because there's absolutely zero cross-reactivity between the two different classes.
Next up, we really have to talk about systemic toxicity. Look, local anesthetics have one job, right? To stay local. But sometimes they don't. Whether it's from accidentally injecting directly into a blood vessel or just giving way too high of a dose, the drug can escape the local tissue and get swept up into the entire systemic circulation. And when this happens, those sodium channels in the brain and the heart get completely blocked, leading to severe, widespread systemic effects like seizures or dangerous cardiac arrhythmias.
Honestly, this brings us to one of my favorite medical philosophies. Medicine makes perfect sense once you actually understand what the flip you're talking about. Think about it. We started this explainer by learning that these drugs block sodium channels and are highly lipid-soluble. So if they accidentally get into the bloodstream, where are they naturally going to go? Straight to the most lipid-rich, electrically active organs in your entire body, the brain and the heart. The clinical side effects are perfectly logical once you master those underlying basics. It's like a giant puzzle, and the pieces just snap together.
Let's wrap up this explainer with a quick question to challenge your recall. If your patient has an atypical weak plasma cholinesterase enzyme, which specific class of local anesthetics will cause dangerously prolonged side effects? Think back to our metabolic breakdown. Which class gets chewed up in the plasma? I'm going to leave you to ponder that one. Review the material, master these basics, and I promise you will never be that confused neuron again. Stay curious, and I'll catch you in the next explainer.